What's up, Ninja Nerds? In this video today, we're going to be talking about respiratory failure. This is a part of our clinical medicine section. If you guys like this video, it helps you, please support us. And you can do that by hitting that like button, commenting down in the comment section, and please subscribe. Another way that you can really help us, but also help yourself, is go down the description box below. There's a link to our website where I really suggest and really push you guys to become a member, because there we have a lot of awesome things. We have notes, illustrations, question banks. We're developing exam prep courses for those of you who are taking your boards. And we even have some merchandise there that I suggest you guys check out. All right, without further ado, let's talk about respiratory failure. So with respiratory failure, what is the primary way that these patients present? They can look a lot of different ways, and that's why we're going to talk about all these different types of causes of respiratory failure. But oftentimes, one of the most common ways that we look at patients who have respiratory failure is based upon their oxygen saturation. So when they come into the hospital or they go into the clinic, they get one of those monitors that goes on their finger and it gives you an SpO2. And when that SpO2 is rather low, we can potentially suggest that this patient is exhibiting signs of respiratory failure. And then we'll look through the causes of that. Now, I want you to understand some basic physiology, nothing crazy. You need to know that whenever these patients have problems, generally, there's some type of gas exchange process that is occurring between the lungs and the pulmonary capillary bed. That blood, after it's exchanged, will then move into the left atrium. When it moves into the left atrium, it then go into the left ventricle. From the left ventricle, it will then get pumped out into the arterial system. And when it gets pumped out into the arterial system, we can then test that by doing like our arterial blood gases or putting the probe on the finger, which gives us a percent saturation. So whenever you have a patient who exhibits a low, let's say, amount of oxygen within the bloodstream, what do we call that whenever you have low oxygen within the bloodstream? This is called hypoxemia. So it's low oxygen within the bloodstream. And now this can be measured in a couple different ways. One is you can measure it via that pulse oximeter. And the way that we look at that is we say, oh, the patient has a very low SpO2. Or we get an ABG that tells us that they have a low SaO2 or a PaO2. And I'd say the latter one is the more common one that we go off of. So if patients have low SpO2s, low SaO2s, or low PaO2s, these are other ways that we can quantify a patient having hypoxemia. The question arises, what's a low SpO2? It can vary from person to person, patient to patient, but on average we say something less than 90%. And then for the PaO2, we go to the range of a patient having something less than 60 millimeters of mercury. So I'm going to put less than 60 millimeters of mercury. These are the ways that we can quantify a patient having hypoxemia, which may define their respiratory failure. We just have to figure out why is there this problem within the lungs where gas exchange is occurring between the pulmonary capillaries. So let's go through that. The first reason one of these patients can develop hypoxemia is called a VQ mismatch. Now, when patients have VQ mismatch, the primary problem is they have poor ventilation to their alveoli. We've already talked about this in great detail in pathophysiology, but concept here is something, in some way, shape, or form, there is poor ventilation. Maybe this alveoli is filled with a little bit of pus or fluid. And in that scenario, you can't get the amount of oxygen molecules to go into this alveoli as you usually would. If this thing didn't have that material, you wouldn't have a problem. Or if there was something kind of like within the airways that were kind of like mildly obstructing the airway. These are concepts where ventilation is now going to be poor to this alveoli. And same thing, look at this alveoli over here. This sucker's collapsed. Am I going to get good ventilation to this alveoli? No. So the concept here is that these patients are going to get poor ventilation. But the amount of blood flow moving through the pulmonary capillaries in these patients is normal. That's why there is a mismatch. It should be normal and normal. So if I have normal, what we call Q-perfusion, and decreased ventilation, this is what causes the mismatch. If there's poor ventilation, there's not enough oxygen molecules getting to these alveoli, I won't be able to move the oxygen, the amount that I want to, into the alveoli, from the alveoli into the pulmonary capillary blood. And so when the blood leaves here, as it moves through, what's it going to show? It's going to show a low oxygen concentration. And that could be via these things that we just talked about. But you have to ask yourself the question, what is this process here? Well, this process here, where we have low ventilation, could be due to alveolar filling. So the alveoli are filled Filled with what? Well, it could be a bunch of different things. It could be they're filled with pus in the scenarios of pneumonia. It could be they're filled with fluid, like in pulmonary edema. It could be that they're filled with blood, like an alveolar hemorrhage. So if you understand that they're filled with something that's reducing the ventilation to that alveoli, then you have a very strong concept of why ventilation would be reduced. So there's increased alveolar filling, reducing the ventilation to that alveoli, and therefore less gas exchange. What about in this scenario? The alveoli is collapsed. So there's increased alveolar collapse. What is it called whenever the alveoli collapse? That's called atelectasis. So if a patient exhibits atelectasis, and there's many different reasons for atelectasis, it could be they're not taking a good enough deep breath in. It could be that in this particular scenario, they have something that's pushing down on their alveoli, like fluid, like a pleural effusion or a pneumothorax, or there could be some mucus within the airways. Either way, these are concepts of where you're going to have VQ mismatch, and then for hypoxemia. One big thing, and these patients, I really need you to remember this. For VQ mismatch, they have a normal or elevated, they usually, more often than not, an increased, what we're going to call minute ventilation, which we express as VE. Meaning, these patients often breathe really fast. So they usually have increased respiratory rates and increased work of breathing, usually as a response of their hypoxemia. They're like, hey man, oxygen isn't good, I gotta breathe faster and deeper. And so oftentimes, more than not, these patients will breathe super, super fast and really work hard and take deep breaths in. And that'll often cause you to clear a lot of CO2. So oftentimes these patients' CO2 tends to be low or maybe just on the lower limit of normal. And that's important to remember here. What about the other scenario where the ventilation is actually normal or maybe even a little bit increased, but the perfusion stinks? So that's another scenario here. So now I have a patient who has poor perfusion. Maybe it's because these puppies are clamped down, or maybe there's a clot right here that is present within these vessels. But either way, maybe the clot's not completely occluding the flow, but there's a little bit of flow coming through there, but it's very, very little. Now, ventilation in these alveoli, is there anything filling them, or do they look collapsed? No. So if that's the case, then this is normal, this is reduced. So ventilation will be normal. You'll be able to get a good amount of air here. You'll be able to allow for some gas exchange to occur here, but it's going to be very little. There's very little blood that's squeezing through this area to pick up the oxygen. And so because of that, you're not going to be picking up as much oxygen because you're not getting enough blood flow to the area. So these patients will also drop their oxygen in the form of an O2 saturation, an SaO2, or a PaO2. What's the cause for the low perfusion? Pulmonary vasoconstriction or a pulmonary embolus. I'd say by far it's going to be pulmonary embolism. In the rare scenarios, it could be some type of intense pulmonary vasoconstrictive mechanism. But here's what I want you to remember. Patient comes in, hypoxemia. If they have hypoxemia, think about VQ mismatch, either a ventilation or a perfusion problem. Same thing exists though over here, where these patients will also potentially, because of their hypoxemia, they will usually have increased respirations, increased work of breathing, so they will blow their CO2 down. Sometimes patients with pulmonary emboli will have some degree of increased dead space, so they could potentially have their CO2 a little bit more normal than usual. All right, that's VQ mismatch. The next reason of why is going to be a patient who develops something called hypoventilation. Now this is really, really important that you get the point here. These patients do have a low minute ventilation. So they have a very low VE, minute ventilation. Now what that means is that their respiratory rate is either super, super low and they're not breathing at all or breathing really, really slow, or their tidal volume, which we represent as VT, is really low. They're taking very shallow breaths. If that is the case, that would be the primary reason why these patients don't bring enough oxygen in and get enough CO2 out. That is the big, big concept here. So what I want you to understand is in both of these scenarios, you know what the big overarching theme is? Is ventilation is reduced so they don't get CO2 out and they don't get oxygen in. So these patients will have both a low O2 and a high CO2 potentially. So they may have a high CO2 and a low O2. This is the big thing to remember about hypoventilation. Hypoventilation is one of those that can cause elevated CO2 and maybe a normal or even decreased oxygen. Question comes, why are they hypoventilating? Why are they not getting enough oxygen coming through their big airways and into the small airways? There's no VQ mismatch. There's no pus or fluid or any kind of alveolar collapse. It's just they're not taking deep enough breaths or they're not breathing fast enough. So the amount of air that they're moving into these air columns is reduced. Therefore, less oxygen and less CO2 being cleared. If that happens, that's why they build up. What's the causes? Make it super simple. Go back to physiology. You have a respiratory center. It sends signals to your actual muscles, to your nerves that go to the muscles, cause them to contract. Diaphragm contracts, intercostals retract, you take deep breaths in, and you exhale. But the rate at which you breathe is determined by the respiratory center. So if I have CNS depression, let's say I jack this thing up. So if I have CNS depression as one potential cause here, what's that going to do to my respiratory rate? That's going to drop my respiratory rate. And if I drop my respiratory rate, I drop my minute ventilation and I accumulate CO2 and I potentially don't get enough oxygenation. So now that's going to be one of the problems. Why am I depressing the CNS? One is a cerebrovascular accident. You stroke out this area. Or more common is usually drugs. So drug overdose. There is many different types of drugs, but I'd say the big ones to remember here are going to be opiates. So if someone takes way too many opiates or they take way too many benzos and they overdose on these. All right, if that happens, they have a decreased respiratory rate, decreased signals, decreased exertion of the muscles. What if I damage the nerves or I damage the muscles and they don't contract? If they don't contract, I can't take a deep breath in. That lowers my tidal volumes, lowers my minute ventilation. Same concept, neuromuscular dysfunction would be another big one. And again, what's the overarching theme with this one? That it's going to drop my tidal volumes. Sick. Now, if that happens, I don't take deep breaths in, I accumulate CO2 and don't oxygenate. What's causes here? One is called Guillain-Barré syndrome. Another one is called spinal cord injuries. Another one could be like myasthenia gravis. Another one could potentially be muscle exhaustion or fatigue. These are big causes. So if I damage my spinal cord, I damage potentially I demyelinate my neurons, or I cause neuromuscular dysfunction, or I weaken the muscles, that's all going to cause them to not take deep breaths. Last but not least, what if I obstruct the airway and I can't get CO2 out and then my lungs hyperinflate? Ooh, that's interesting, right? So the last one could be airway obstruction. If a patient has airway obstruction, and in some other scenarios it could just be airway disease, what this does is it does something super weird. They actually breathe fast, but their lungs become hyperinflated and they can't take in deep breaths. So what happens to their tidal volume? It drops. This is classic, and I mean classic, of patients who have exacerbations of reactive airway disease. So this would be an acute exacerbation of their COPD, or it could be an asthma exacerbation. These are super common because they'll cause so much bronchospasm you can't get air out. So they hyperinflate, their lungs are so big they can't take a deep breath in. These are all mechanisms here. This is the one that I really want you to remember, where all the other ones will probably blow down their CO2. This is the one where you'll probably rise your CO2. Okay, come to the next one. We come to the severe guys. These are the patients who are like refractory hypoxemics. This is usually what we call an extreme low VQ mismatch. So we call this a pulmonary shunt. This would be a patient who has one of these things up here, but the worst case scenario. Imagine I take this entire alveoli and I fill it with fluid or pus. So in this particular scenario, I have the worst case. I have severe alveolar filling. If I fill these puppies to the absolute brink, that is a big, big problem. So if I have severe alveolar filling, I'm gonna get literally, what kind of ventilation into this? Can you get any air into this thing? No ventilation. What if this puppy collapses completely? Can I get any air into this one? Pretty much no. So if I have a patient who has severe alveolar collapse or severe alveolar filling, the process that happens here is that they get no ventilation that occurs here. So I'm trying to get air that comes down here, but that's blocked. Or I have something that's occluding this airway or causing it to collapse. That's blocked off. I won't even ventilate these dang things. So therefore, gas exchange doesn't even occur. This process here is inhibited. And even though the perfusion is actually maintained relatively normal, blood is just going to flow on right through here with almost no gas exchange whatsoever. So what happens to the PaO2 here, or the SpO2? Drops. So these patients have extremely low oxygen levels. All right. Question then comes, again, same thing. What's causing this? Severe alveolar filling. This is very, very common of patients who have what's called ARDS. I'd say it's probably one of the biggest ones. Another one could be if they have severe pneumonia, like really, really bad pneumonia, or severe edema. So severe pulmonary edema can also do this. Or if they have like diffuse alveolar hemorrhage. It's just the worst case scenario of these things. That's really the primary trigger here, okay? The last one is if they alveolar collapse. So they have intense alveolar collapse, like the worst case scenario. So this is like the most severe atelectasis that you can think of. If their alveolar collapse is intense, this is usually two things. It's usually severe atelectasis, or it's a proximal mucus plug, so a big plug somewhere within the airways that they get no airflow. So this would be a mucus, what we call mucus plug. These are two big reasons of why patients can develop an increased alveolar collapse, no ventilation, no gas exchange, severe hypoxemia. Again, these patients will usually have increased ventilations. They will breathe pretty dang fast because they're trying to improve their oxygenation. So their respiratory rates will go up, their work of breathing will go up, they'll look like hot crap. And because of that, they will sometimes blow their CO2 down to normal, or they will completely drop their CO2. Same thing for the extrapulmonary shunts. These patients, same thing. They'll probably increase their minute ventilation. But what's different between a pulmonary and an extrapulmonary shunt? The blood flow isn't just bypassing in the pulmonary arteries, it's bypassing outside the pulmonary arteries. So the best example of this is that blood is usually, oxygenated blood will move to the left heart, right? From the lungs. So this should be rich in oxygen, this whole thing here. But if for whatever reason, I splint open a hole between the heart and deoxygenated blood diverts over into the oxygenated blood, and I have blood to go from the left atrium, left ventricle, into the arterial system, I test it, what am I gonna find? Deoxygenated blood. So if I were to imagine here, blood's coming out of the heart, what am I gonna see as the O2? It's gonna be low because I'm mixing blood here. They're gonna have crazy low O2 levels. Now, what's the reason for this? The reason is there's some type of cardiac shunt. And this is usually two examples here. One is the patient has what's called a atrial septal defect. They have a PFO or they have a VSD. And what happens is the blood is shunting across these holes within the heart. But this cardiac shunt has to be under high pressure. The right heart pressures have to be high enough to push blood over to that side. The only thing that would do this is you'd have to have a cardiac shunt, and the patient would have to have pulmonary hypertension. So they would have to have pulmonary hypertension in the presence of a cardiac shunt for the pressure to be high enough to shunt the blood over. That is the big difference here between these patient populations. There is another rarity called pulmonary AVMs, but I don't want to take too much time with that. The last concept to understand here is in these patients that come in with hypoxemia, it is really, really important that you kind of use different tests. So if you test them and look at their SpO2, you look at their ABG. Another thing is giving them 100% oxygen. And when you give them 100% oxygen, it takes a look to say, which one of these would correct? And so that's the big thing here. So with VQ mismatches, you give them 100% oxygen, they will improve because some of their alveoli are healthy. They're well ventilated, some are well perfused. Hypoventilation, you give them more oxygen, they actually will improve. But these, you give them oxygen, they have almost no good alveoli or good perfusion here. This is gonna literally not change with oxygen. All right, now that we've covered this, let's move into the diagnostic process of respiratory failure. All right, so now we have to learn how to diagnose respiratory failure. So we're gonna go through and say, okay, Zach, how do I determine if there's a type 1? How do I determine if there's a type 2 respiratory failure? I don't really know that stuff. So let's go through it. So first thing is look for the patient who appears to be in respiratory distress. That might be one particular sign. They're breathing really, really fast at 30 breaths per minute. They're using accessory muscles. They're using nasal flaring. They have intercostal retractions. They don't look good. Look at their vitals. What does their O2 saturation suggest? Is it less than 90%? They may have hypoxemia. And so then I got to get an ABG because I think the ABG is going to help me to determine, is this a type 1 or a type 2? I know that in type 1, you have to have a low PaO2. And again, that has to be less than 60. In type 2, you have to have an elevated PaCO2, generally greater than 45 or greater than 50. And it doesn't really matter what the PaO2 is for that one. It can be low, but I just have to be able to differentiate because that's going to tell me if it's hypoventilation or it's going to tell me if it's a VQ mismatch, shunt, or diffusion capacity problem. So that's right away the thing I'm going to do. If I obtain it and I see a PCO2 of greater than 45, I know it's hypoventilation. So then I got to go and think, is it a CNS depression issue? Is it neuromuscular failure? Or is it a COPD or asthma exacerbation? And that's where the history comes into play and other tests. If that is not the case and the PCO2 is normal or decreased, then I know it's not hypoventilation. It's got to be something else. Now, really quickly, they'll say, okay, do 100% oxygen. But before you even do that, one of the big things that can be helpful is that there's only one of these. It's called the decreased diffusion capacity, which we see in ILD. Usually this is the only one that'll happen with exertion. So if you get the patient up, you start walking them around the unit and they start having, decreased oxygen saturation, or they have a low PaO2 on their ABG after you walk them, that would be suggestive of an impaired diffusion like an ILD disease. But we're going to go to the shunt and the VQ mismatch. You give these patients 100% oxygen. This is really the test. If you give them 100% oxygen and the hypoxemia does improve, so their SpO2 goes up or you get an ABG afterwards and it goes up, that's suggestive of a VQ mismatch because there's some ventilation that's getting there. So then you got to think, okay, from the VQ mismatch, which one could it be? Well, how do I really determine that? Get a lot of different tests. Get some chest imaging. Get a chest x-ray. Get a chest CT. It'll look for a lot of these problems. It'll say, is it atelectasis? Is it pneumonia? Is it pulmonary edema? Is it some type of mucus plug? Or is it a PE that I do a CT pulmonary angiogram to prove? Hypoxemia does not correct. It's a shunt. So it's likely a shunt. And you have to determine, is it a true pulmonary shunt or is it a true intracardiac shunt? And so oftentimes I just would get an echocardiogram. An echocardiogram would help me to say, oh, there's an ASD, there's a PFO, there's a VSD, and I could see the blood passing across from the right to the left. And if the echo isn't the answer, you can also get chest imaging to make sure that you rule out a severe atelectasis, you rule out ARDS, you can rule out severe pneumonia, things to that effect. So it's really important after that to find out a little bit more about the etiology. All right, so we have a patient who has respiratory failure. You want to be able to treat these patients appropriately. And so there's different ways that we can do this. One of the ways that we can do this is non-invasive ventilation. One of the best methods I like to use in patients who have a lot of pulmonary secretions and they're hypoxemic is usually high flow nasal cannula. And you can give them a lot of FiO2 and you can give them a lot of volume of air that rushes into the lungs, and it helps with kind of mucokinesis, moving a lot of secretions out, especially in pneumonia. And it's also good in patients who have very low oxygen levels. This is a really good one. In patients who maybe have a different scenario where they may require something called bi-level positive airway pressure, also known as BiPAP, there's two really big scenarios that I want you guys to remember for this one. One is if they have hypercapnic respiratory failure. So this is your type 1s. If they have the type 1, these are the type 2 respiratory failures. I apologize. For the type 2 respiratory failures where the CO2 is really, really elevated, this is the type of kind of non-invasive ventilation that you'd want to perform. Another one is cardiogenic pulmonary edema. If a patient has CHF, they have a lot of pulmonary edema in their lungs, BiPAP is actually really good to reduce the work of breathing and also reduce the actual pulmonary edema via that high amounts of PEEP. And it also will improve cardiac output. So BiPAP is good in these particular scenarios for type 2 respiratory failure and cardiogenic pulmonary edema. High flow is good for oxygenation, especially in a patient with a lot of pulmonary secretions and hypoxemia. Now, if a patient fails non-invasive ventilation, oftentimes what we'll go to is endotracheal tube intubation. And this is usually going to be in refractory respiratory failure. In other words, we've tried high-flow nasal cannula to oxygenate them. We've tried BiPAP to reduce their work of breathing. We've tried all the therapies to treat the underlying cause. They're still refractory, then you may have to intubate them. That leads to the next step. If I have a patient on the ventilator, how the heck am I supposed to know how to manage them? Well, the first thing you want to know is what's the mode that we have the patient in. Are they in what's called CMV, or controlled ventilation? So this is a mechanical ventilation strategy where we actually set the respiratory rate that we want for the patient to have, and we set the amount of tidal volume, the volume that we want to deliver into the lungs. This is usually good for a patient who is not taking spontaneous breaths. In the other scenario, if a patient is taking spontaneous breaths, we should let them breathe on their own. Don't let them be dependent upon the ventilator. And so this is usually what we call PSV. So it's called pressure support or patient-controlled ventilation, where you can actually allow for the patient to breathe at their own respiratory rate and their own tidal volume. All you do is you set the PEEP and the FiO2. That leads to the next step. Oftentimes in the exam, they may say, okay, you have a patient who is being ventilated, their PCO2 is really high. What do I do to reduce their PCO2? Well, I want you to remember two things. One is respiratory rate and tidal volume. If you increase the respiratory rate or you increase the tidal volume, it'll drop the PCO2. If you have to pick between the two, respiratory rate is going to be the more effective one. Same way, test your knowledge. If the PCO2 is low, what do you need to do? Then you need to decrease the respiratory rate or decrease the tidal volume, because that will help to bring it up. You're just trying to reduce their ventilation. So PCO2 is tied to respiratory rate and tidal volume. The next one is PaO2. What if it's too high? Well, if the PaO2 is too high, that may sound dumb, but what do I want to do? Don't I want their oxygen to be really high? No, it's actually kind of dangerous. You want to reduce the PEEP or the FiO2, and that'll reduce the PaO2. Same scenario, PaO2 is low, increase the PEEP or increase the FiO2. That'll increase the PaO2. The concept behind PEEP is that here's an alveoli. It's not getting good ventilation. You give them a lot of pressure at the end of expiration, and they don't collapse. They stay stented open and big. So now they can perform good ventilation, and they can actually perform gas exchange. But if you take the PEEP away, they'll de-recruit, go back to that small size, and they won't perform good ventilation. So this keeps the alveoli stented open and will be able to perform gas exchange. That's one of the big things about PEEP. What about PIP? This is called positive inspiratory pressure, or peak inspiratory pressure. If the PIPs are really high, that means that there's a lot of resistance to airflow through the ventilator tube. Maybe it's a small tube, maybe it's kinked, maybe there's a lot of mucus within the tubing, or they're having intense bronchospasm. That's important to remember. If the PIPs are low, that means that there's probably something wrong with the ventilator circuit. There's probably an air leak somewhere. The big one here that I really want you to remember is called the plateau pressures. Plateau pressures are a measure of kind of the, if you take an inspiratory hold, it kind of gives you the pressure within the airway at the end of inspiration. So it's really important for helping to determine the risk of lung injury. If plateau pressures are really high, that means that the lung compliance is not very good. A patient likely has ARDS or pneumonia or things to that effect, or they're air trapping a lot. And so this is really dangerous. And so whenever patients have very, very high plateau pressures, it's important to reduce the tidal volume so you don't cause barotrauma to the lungs. The last thing I want to talk about is whenever you have a patient who maybe was intubated for a particular issue and you improve that underlying issue, you don't want them to be on a ventilator forever, so you want to get them liberated from it. And so what we do is what's called SBTs, or spontaneous breathing trials. And we look at a couple different things. Did they resolve the reason why they were intubated? And if they did, good, that's one thing. Second thing is their FiO2 requirements very, very minimal? Okay, good. Is their PEEP really, really minimal? Good. Is their RSBI, which is their rapid shallow breathing index, are they breathing really, really fast and not taking very good deep breaths? These are all things that would say that a patient would likely succeed and be able to be extubated. If they don't meet these criteria, you should probably not extubate them because they'll have a high risk of being re-intubated. Big things that I really want you to remember is ventilating a patient comes with complications. If you have really high tidal volumes in these patients, especially in ARDS, or really high plateau pressures, you can really rupture those alveoli and cause barotrauma. That's one really big thing. It can cause what's called ventilator-induced lung injury. You want to avoid that. The other thing is that you don't want to give them too much oxygen, because if you give them too much oxygen, you cause VQ mismatching, you cause a lot of free radical formation, a lot of inflammation. That can also worsen the actual lung disease. So avoid that. And lastly is that these patients are at high risk. The longer they remain intubated, the longer there is the risk for them to develop a VAP, a ventilator-associated pneumonia. So you want to try to liberate them as soon as you can from that. All right, my friends, that covers a monster of a topic, in that being respiratory failure. I hope it made sense. I hope that you guys enjoyed it. And as always, until next time.